Okay, fine. So with respect to the clinical bacteriology, today we'll be discussing one by one the order, okay? But I'm going to be discussing the question answer aspect of it also. Okay, so while discussing the concept, I'll give you like a case scenario so that you guys have an idea about how the questions are asked. Okay, so with respect to your gram-positive bacteria, so first starting with your lab algorithm, okay? So we have your staph, your strep, okay? So we also have your listeria, your clostridium, okay? So now what we have to understand is the first division of your gram-positive bacteria is based on the shape, okay? So whether it is a bacilli or a cocci or a branching filament, okay? Then we divide whether it's a aerobic or a non-aerobic or anaerobic organism. Then we divide whether it is catalase negative or catalase positive. Okay, catalase positive and your coagulase positive. Okay, so the catalase positive, you have to remember each and every division. So they will give you a clue like a patient who's coming, who's having a catalase positive and who's also having a coagulase positive. Okay, so that's going to be your Staphylococcus aureus. So if there is a patient who's actually catalase positive but coagulase negative, that is going to be your saprophyticus or epidermidis. So saprophyticus is the most common cause for the UTI, the second most common cause in your women. Okay, so now the reproductive age woman. So then they can also ask you your staphylococcal epidermidis is a case scenario of infective endocarditis, like a patient who's on your urinary catheters or a patient who is basically on even your prosthetic heart walls. Okay, so now anything with related to your skin, anything with related to your skin, they can ask you this kind of presentation. That is your staphylococcus epidermidis. Okay, so now that is basically your catalase positive organisms, which is divided into whether it is coagulase positive or negative and whether it is novobiosyn sensitivity or not. Okay, so another set of organisms that we have is catalase negative itself. So in the catalase negative only we divide based on your alpha or beta or your beta or your gamma hemolytic. Okay, so one second, I think I pressed the wrong button. Yeah, is the screen visible now? Okay. So, yes, under your catalase negative organisms, we divide them on the basis of whether they have a complete hemolysis or whether they're having a partial hemolysis or whether they're having a no hemolysis. Okay. So, for example, on the basis of this, again, on the basis of your optokin or your bacitracin sensitivity, they will ask you organisms. Okay. So, now we will directly go to the concept like one by one, all the staphylococcal and your streptococcal organisms, what we have to know with respect to that. Okay. So now, can anybody tell me what all clinical conditions you guys know with respect to Staph aureus? Anybody? Okay, so I'll give you a case scenario. Okay, so first is let's say we have a patient. Okay, they are 68-year-old. Okay, they are 68-year-old. So she's a woman. Okay, so 68-year-old woman. She's coming to the hospital because she's on chemotherapy for her leukemia. Okay, so after the chemotherapy, she is developing a skin infection. After the chemotherapy, she's developing a skin infection around the intravenous site, around the intravenous site. Okay, so now we are also seeing that the blood culture, okay, when the blood culture was taken up, so the patient is now having a Staphylococcus aureus. The blood culture is showing a Staphylococcus aureus. Okay. So one day later, she's having an increase in creatinine. She's having an increase in creatinine. Okay. So a 68-year-old female who's on chemotherapy for the leukemia now coming with a skin infection around her IV site. Right now, the blood culture is showing Staphylococcal aureus. She's having an increased creatinine, showing that there is a kidney injury. So now we have to understand maybe the patient is having a Staphylococcal aureus which is causing a post-infection related glomerulonephritis. Okay, so which is causing a post-infectious related glomerulonephritis. Okay, so post-infectious, that is your PIGN. So the takeaway point from this is PIGN can be caused by two bacteria. One is going to be your Streptococcus, another is going to be your Staphylococcus. Okay, so most commonly you guys would have heard about your pharyngitis and a patient coming with PIGN. Okay, with 2 to 3 weeks of duration. So PIGN is usually your streptococci, but it can also be because of staphylococcal related. So staphylococcal related means how will the patient come with your presentation? I told you there was an IV site and they had a skin infection. I gave you a presentation of skin infection. Okay, so now any patient who is having an increase in creatinine, increase in hematuria or your cast is basically seen, which is your kidney presentation, but the starting course of it is staphylococcal associated glomerulonephritis. Okay, so I'll give you one more question with staphylococcus. Okay, how they can ask you is, let's say we have a patient, okay, who is, let's say we have a patient who's 26-year-old. Okay, so 26-year-old man, he's coming because he is receiving antimicrobial treatment for the methicillin resistant staphylococcus aureus. Okay, so he is receiving antibiotic treatment for the MRSA. Okay, so MRSA associated endocarditis. MRSA associated endocarditis. So sure, now what happened is, after the antibiotic is given like as a bolus intravenously, the antibiotic is given as a bolus. Okay, it was given intravenously. Now the patient is very flushed. Okay, the now the patient is very flushed, and this flushing is basically seen around the face and it's seen around the neck. Okay, so now we have a case scenario of a patient. They are very directly given you with staphylococcal aureus. Okay, so now the staphylococcal aureus is actually MRSA. So MRSA is methicillin resistant. So MRSA is resistant staphylococcal aureus. Okay, so now if the patient is on this, we treat them with vancomycin. Okay, the treatment of your MRSA is basically vancomycin, and the vancomycin is only causing that flushing around the face and the neck. Okay, so here they have given you a staphylococcal case scenario, but they're asking you related to your pharmacology, because vancomycin, when they are giving it, okay, it's like a vancomycin infusion reaction. So it is a non-allergic release of your histamine, non-allergic release of your histamine after your normal usage or rapid administration of your vancomycin. So when you give vancomycin as a rapid administration, you can have an infusion reaction. So this is just a case scenario for patient who's having methicillin resistant staphylococcal aureus. So this is one of the other way where they can give you staphylococcal aureus. So let's go in deep about that. So first of all, in your staphylococcal aureus, what is the basic about it? Like, how will they give you in description wise? It is a gram positive beta hemolytic catalase positive coagulase positive cocci. Okay, so you have to remember gram positive beta hemolytic catalase positive coagulase positive cocci. So this is going to form yellow colonies. This is going to form yellow colony. This is different from your actinomyces, which is having that yellow color sulfur granules. Okay, both are different. This forms yellow colonies on your blood agar. Okay, this forms yellow colonies in your blood agar. So that is another clue or finding that you have to know. Okay, so now very commonly they try giving about like what it ferments. This basically ferments your mannitol. Okay, so this ferments your mannitol. Okay, so the clues or the description or the characteristics of the bacteria is, it's a gram positive beta hemolytic catalase positive coagulase positive cocci in clusters. You should remember it's a cocci. You should remember it's seen as cluster also. Okay, so it is small yellow colonies on the blood agar. It's going to ferment your mannitol. Okay, so mannitol means like how, what happens is that you have your pink color turning into yellow. Okay, when compared to the other staphylococcus, this actually turns your pink color into yellow. Okay, so now what is the virulence factor? Okay, so what is the virulence factor for your staphylococcal aureus? So protein A is a virulence factor for your staphylococcal aureus. So what should we know about that is, so your protein A is going to bind to your FcIgG and it's going to inhibit the complement activation and the phagocytosis, basically protecting its survival. Okay, so now you just have to know protein A and the immunoglobulin that is going to be your Ig. Okay, IgG. So now the usual mechanism is that it's going to inhibit your phagocytosis and it's going to be very important for the survival of the bacteria. So now all you have to know is that, so this actually can cause four important diseases. Okay, so one case scenario we saw was a MRSA. It can also cause a VRSA, vancomycin resistant staphylococcal aureus, and this can also cause a scalded skin syndrome. Okay, you have a scalded skin syndrome and you also have a toxic shock syndrome. Okay, and you also have an inflammatory disease. So now you have to divide them into two parts, whether it is an inflammatory disease or whether it is toxin mediated. So because if it is an inflammatory disease, so now you have so many options here. So the reason is because it is coagulase positive. Okay, coagulase positive means it's going to form a fibrin clot around itself. Okay, so when it forms a fibrin clot around itself, it's going to become an abscess. It's going to become an abscess. Okay, so apart from the skin infections, you should also remember that it's going to form a fibrin clot around itself. Okay, so it's going to form an abscess. Abscess can be anywhere. Abscess can be anywhere. So the next thing is your endocarditis. Commonly, they will give a patient of IV drug abuse. Okay, IV drug abuse, and the patient is now getting an endocarditis. So that will be the usual presentation. Okay, and we should also know staphylococcal is the most common cause for the arthritis and the osteomyelitis. Remember them together. So with respect to the bone, the most common cause for your infection is staphylococcal aureus. And unless and until the patient is actually having a asplenia. Unless and until the patient is having asplenia, if a patient is having a sickle cell anemia or a asplenia and they are now coming with an osteomyelitis, the answer is going to be salmonella. Okay, so now you have to understand that is because encapsulated organisms are quite common when you don't have the spleen, so that should be your major priority. But if you're asking just a osteomyelitis patient, what is the most common cause? It's going to be your Staphylococcal aureus. Okay, so now here certain more concepts that you have to know. They will ask you hepatic abscess very commonly. They will ask you hepatic abscess very commonly. That is because you have a hematogenous seeding, like a spread within your blood. Okay, hematogenous seeding is actually seen, and you can also have a suppurative parotitis. Okay, so Staphylococcal aureus, which is going to usually colonization is in the nares. Okay, nares, and it's seen in the axilla, and it's also seen in the groin. So this is a common area where it colonizes. Okay, your Staphylococcal aureus is going to be colonizing in the nares, in the axilla, and in the groin. Okay, so now this is going to form a fibrin clot around itself. It's going to form an abscess. It can also, like for example, a patient is coming with influenza. Okay, after influenza, you can also have an added on bacterial infection, right? So that's going to be your pneumonia. A patient who's coming with a parenchymal damage. Okay, so now you can have an infection of your parenchyma like pneumonia. You can have a clot forming around itself like an abscess. You can have an IV drug abuse patient coming with an endocarditis. You can have the most common arthritis and osteomyelitis in a young patient usually, or the very older patient. Two scenarios. Okay, so now you can also have like a surgical infection. They will tell you like a patient who's after the surgery, they're presenting with at the surgical site, you have fever, you have erythema, you have pain and tenderness. So surgical infections are also given as one of the case scenario, and suppurative parotitis. Okay, you should add on one more thing here is parotitis. It's suppurative. So you should know that you should look for the clue that whether it's purulent or not. Okay, and hepatic abscess. So these are all the case scenarios. I think around 7 to 8 case scenarios are possible with your inflammatory disease of Staphylococcal aureus. So now coming to the toxin mediated, we basically have a lot of types. Okay, so one of that is going to be your toxic shock syndrome, that is TSST1 super antigen. Okay, so what we have to know with respect to that is, so this TSST1, okay, is a super antigen. It's going to bind to the MHC class 2. This is going to bind to the MHC class 2, and it's going to bind to the T cell receptor. Okay, so now when it is binding to them, it is going to cause T cell activation. Okay, so now your TSST1, which is binding to your MHC class 2 and your T cell receptor, it's going to cause a T cell activation. Okay, so now what we have to know is that case scenarios with respect to that. Okay, so the case scenarios means like a patient who's coming with vaginal like tampons. Okay, someone who's having tampons, someone who's on nasal packing. Okay, so now you have to remember your TSST1, which is basically binding to the MHC class 2 and the T cell receptor, which is causing your T cell activation and the cytokine release, is going to be seen with scenarios like a patient who's on your tampons or a patient who's basically on your nasal packing. Okay, so what will be the presentation of them? The presentation of them is it can range from your fever to your end organ failure and shock. Okay, so that much variety of symptoms we have. So this can start like a fever, vomiting, rash, and it can end up with shock, end organ failure, you do desquamation. Okay, so it's a wide range of symptoms with respect to that, but I just want you to remember the scenario. Okay, so what is desquamation? Desquamation is a very important symptom of your TSST1. Okay, it is basically happening only in the palms and soles. Okay, so this desquamation is very particular for the palm, and it's very particular for the sole, which is going to be happening like 1 to 2 weeks after the onset of the illness. Okay, which is going to happen 1 to 2 weeks after the onset of the illness. Okay, so when you look for a toxin mediated TSST1, the scenario is like a tampon or a nasal packing. Okay, so then you have to think about your MHC class 2 T cell activation. Then you have to think about your desquamation, especially in the soles and in the foot. Then you should also think about your lab results. So your entire liver enzymes and your bilirubin is going to be elevated. Okay, that is your AST, ALT, and bilirubin is going to be elevated. Okay, so now toxic shock-like syndrome, okay, is another scenario where it's going to be seen with your Streptococcus pyogenes. Okay, which is going to be seen with your Streptococcus pyogenes. Okay, so you have to be very careful. They can give you a Staphylococcal aureus toxic shock syndrome, or they can give you like a Streptococcal pyogene also. Okay, so now coming to the next toxin mediated one, I'll just push the screen down. I'll give you one more example, like how a toxic shock syndrome is going to present. Okay, just a case scenario. Let's say we have a 30-year-old woman. Okay, so 30-year-old woman is coming to the ER. Okay, so her presentation is 30-year-old woman. She's coming to the ER with the presentation of red color rash that is seen on her abdomen. Okay, so this is there for the past 2 days. This is there for the past 2 days, and the patient is now coming with the complaints of lightheadedness. She's coming with your headache and vomiting, and she's also coming with muscle pain. So she's also coming with muscle pain. Okay, so now her scenario is that she had nasal packing that was basically done in the hospital around 4 days ago because she had a nosebleed. Okay, so now in the physical examination, they're giving a case scenario of fever around 102 degrees and BP around 91 by 51. And let's say the pulse is also tachy. Okay, 109 by per minute. Okay, so the nasal packing is all fine. It's there in the place. Okay, no oral lesions or mucosal lesions you can see. Now they're asking, like, why this patient after 4 days of nasal packing, why is she coming with the presentation of, the entire nosebleed and the entire fever and the hemodynamic instability and everything? It's because the patient is having a toxic shock syndrome. The toxic shock syndrome is characterized with your fever, it's characterized with your rash, it's characterized with your diarrhea, vomiting, myalgia, shock, okay, and your end organ failure. It's quite a lot with respect to the symptom presentation. So you have to know it's because of your cross-linking of your MHC class 2, that is your T cell receptors. It's going to cross-link with the MHC class 2 molecules on the antigen-presenting cells with the beta chain of the T cell receptors. Okay, this cross-linking, why I'm specifying this much is, they will give you this as a clue in the exam. So they will tell that this cross-linking is you're producing your IL-2, it's producing your interferon gamma, it's producing your tumor necrosis factor alpha from your T cells. So that's why this cross-linking is very important. Okay. So this is actually caused by a endotoxin or an exotoxin can also be asked. So you need to know this is caused by an exotoxin. Okay. The toxic shock syndrome mechanism, this is caused by your exotoxin. Okay. So now moving on to the next toxin, we have scald skin syndrome that's called as an exfoliative toxin. Okay. So have they given about that here? Okay, I think it's there somewhere in the first aid, but I'm not able to locate right now. But what I want you guys to remember is a patient who is having an exfoliative toxin that is called as your scalded skin syndrome. Exfoliative toxin is SSSS. Okay, scalded skin syndrome. Okay, so now what we have to remember by that. So this epidermolytic or exfoliative, however you remember, the key words that you have to know is that it is epidermolytic. It is epidermolytic. It has a toxin and a B toxin. So these are going to be against your desmoglein. It's going to be against your desmoglein 1. This is basically present in your stratum granulosum layer. It is present in the stratum granulosum layer. So now that means what we have to understand, it's against your desmoglein. If it's against your desmoglein 1, it's going to be like a localized form. The presentation will be bullous impetigo. So a patient who's coming with a bullous impetigo, okay, or a patient, another clue is that they're going to be having pain and the skin rash. They will have both your rash and the pain. Or a patient whose skin is slipping off with gentle pressure. So when you give gentle pressure itself, your skin will slipping off of the skin. That's called as your Nikolsky sign. Okay, that's called as your Nikolsky sign. Okay, so now if a patient is having epidermolytic toxins of A and B, which is against your desmoglein 1 in the stratum granulosum, which is basically seen with your bullous impetigo as a presentation, Nikolsky sign, or your pain associated with your skin rash, all these are one of the clues for your staphylococcal scalded skin syndrome, okay, which is an exfoliative toxin. Now, one more thing you can have with your staphylococcus common was your food poisoning. Okay, so like a rapid onset food poisoning. For that toxin is called as your enterotoxin. Okay, so in the mentioning, they would have given one is your toxic shock syndrome, next is scalded, next is your enterotoxins. So what do these enterotoxins do? Enterotoxins, whenever you ingest, okay, it's a pre-formed toxin. Okay, it has a very, very short incubation period, maximum of around 2 to 6 hours. Okay, so they have given here food poisoning pre-formed toxin of 2 to 6 hours, Okay, so you have to remember the exact time period because after that time period, the organism is different. Okay, so this usually will come with non-bloody diarrhea. Okay, you have to remember that because your rods, that is your salmonella or your shigella, or when you're talking about the other bloody diarrhea causes, it's different. Okay, this comes with a non-bloody diarrhea and your usual MSS and cramping. Okay, so now this enterotoxin, what you have to remember apart from the content that's given here is that it is your heat stable. Heat stable means when you cook also, it's not going to be destroyed. Okay, so it's not like a to person transmission. Okay, so you need to understand this outbreak can happen with many people because they're eating the same food. Okay, so what people usually think is that, so because it's like an outbreak, they usually think it's transmitting person to person, but it is not person to person, it's because of the contaminated food. Okay, so the most commonly case scenario that I've seen with this presentation is that they give mayonnaise. Okay, like mayonnaise containing food. Okay, for example, your potato, or you're eating macaroni. Okay, your potato or pasta or related. Okay, so mayonnaise related case scenario they will give you, like a patient who's on this particular food item, and then they will enhance the case scenario, like a patient is coming with a non-bloody diarrhea, or just they will say that the patient is having diarrhea and the patient has had vomiting and the patient is having cramping, all within 6 hours. So you need to know within the 2 to 6 hour time period, which is a heat stable enterotoxin, is going to be your rapid onset of food poisoning. That is one of the cause of your staphylococcal aureus. So next is, I gave you a case scenario of MRSA where a patient was on vancomycin and they had flushing. So MRSA is a very important cause for both community acquired and nosocomial, meaning community and hospital. Okay, so now because it is resistant to your methicillin and nafcillin, and they will ask you why it is resistant, you have to know the term. It's because of penicillin binding protein. Okay, so you have to know the resistance is because of PBPs. Okay, because of the PBPs and your mecagene. Okay, so now how do I treat this particular presentation? Now let's say the patient is already having an allergy and they can't take vancomycin. So now they will ask you what is the next two options that we can go for. The next two options that you can go for is clindamycin or your TMP SMX. Okay, so now the next two options that you can go for is your clindamycin, otherwise you can go for TMP SMX. Okay, so now staphylococcal aureus is most importantly your MRSA. I gave you a case scenario of endocarditis. Okay, so I want you guys to remember one more thing. Okay, staphylococcal aureus is the most common cause of tricuspid endocarditis. Okay, so when I say tricuspid, the reason is it's seen in IV drug abusers or substance abuse people. Okay, because all the blood exposure will go to the right atrium, right? And the valve in the right heart is tricuspid. So with specific to your tricuspid endocarditis, suppose if they have not given you any bacteria related clue, like, they have not talked about your catalase, your coagulase, your beta hemolytic, nothing. Just a patient who's coming with tricuspid endocarditis, they're asking you what is the first cause or the major cause of this. You have to choose staphylococcal aureus. Okay, and if they're asking you like a patient with the same presentation of tricuspid endocarditis, they're asking you what is the second most common cause, and it's going to be your Pseudomonas aeruginosa. Same condition, the first cause is staphylococcal aureus. The second cause is Pseudomonas aeruginosa. Especially Pseudomonas patients will come with so much of emboli in the lung after this whole presentation. Okay, so that is one differentiation that you can remember. Okay, so next is your VRSA. I told you VRSA, what you have to take away is that it's a vancomycin resistant staphylococcal aureus. So this you have to treat. So if your normal antibiotics are resistant, we go for vancomycin, we go for your clindamycin, TMP, SMX. If that itself is resistance, you have to go for your quinupristin or dalfopristin. Okay, so these two drugs are basically that. You have to treat with your quinupristin or your dalfopristin. That is for your VRSA vancomycin resistant staphylococcal aureus. Okay, so now some antibiotics generally, that is used, and what are the side effects they will ask. I will make that as a tableau column for you guys. It's very important. So for example, let's say a patient was on vancomycin. Okay, for your MRSA, they're treating with vancomycin. So the mechanism of action of the vancomycin is that it's going to block your glycopeptide polymerization. So they will ask you this term D-ALA, D-ALA. Okay, D-alanine, D-alanine, D-alanine. It basically binds to the D-alanine and it's going to block that polymerization. Okay, so the adverse effects I gave you a case scenario was Redman syndrome. The patient is actually having a Redman syndrome. Otherwise, they can also give you a nephrotoxicity. They can also give you a nephrotoxicity. Okay, that is vancomycin. Another drug that I can use is daptomycin for the MRSA. For daptomycin, what you have to take away is that it's going to create transmembrane channels. Okay, so this creates transmembrane channels. That is the mechanism of action. You have to know the buzzwords. So for daptomycin, it's going to depolarize the cell membrane. How is it depolarizing the cell membrane? By creating the transmembrane channels. By creating the transmembrane channels, it's basically depolarizing your cell membrane. So now you have to remember daptomycin is important. By the adverse effect important for that is your myopathy and CPK elevation. Okay, they will basically cause myopathy. They will basically cause myopathy, and your CPK was going to be elevated. Okay, so the next thing that you have to know with your Daptomycin is that daptomycin is inactivated by your pulmonary surfactant. Okay, daptomycin can be inactivated by your pulmonary surfactant, Okay, so next drug that we can use for invasive, all these are common antibiotics used for invasive MRSA. Next is linezolid. Okay, so linezolid, if you are giving, okay, it is going to go and inhibit your bacterial protein synthesis exactly at your 50 years unit. Okay, it is going to go bind to the 50 years unit, and it's going to inhibit your bacterial protein synthesis. So now what is going to be the adverse effect of linezolid? Linezolid, you have three things. So one is serotonin syndrome, another is optic neuritis, another is thrombocytopenia. Okay, another is thrombocytopenia. Okay, so now with vancomycin, it's red man syndrome and nephrotoxicity. With daptomycin, you have to remember myopathy and CPK elevation. And with linezolid, the takeaway points are thrombocytopenia, optic neuritis, and your serotonin syndrome. Okay, so now with respect to MRSA, you have to know that staphylococcal, when they say MRSA, it's resistant to napsilin, oxacillin, methicillin, all together only we call it as MRSA. So don't expect the case scenario to just say methicillin. They can tell you oxacillin and napsilin resistant also. Okay, but you have to know, even when they say MRSA, it is also meaning that they're resistant to all the beta lactam agents also. So when I say beta lactam agents, that is your penicillin, cephalosporin, and everything. Okay, so when they say MRSA, it is resistant to your oxacillin, napsilin, methicillin, all the cillins. Okay, plus your beta lactam agents. Okay, all together it is going to be resistant. Okay, and they will ask you about the resistance mechanism, that is going to be your PBP, penicillin binding proteins. Okay, so now I told you one extra case scenario, that was your suppurative perotitis, right? So how will they give about suppurative perotitis case scenario is that, because parotid gland is not that much discussed in the first stage, but they ask you in reproductive with respect to mumps. They ask you even with your GI question scenario with the oral cavity lesion, or they can ask you like a staphylococcal related suppurative perotitis. Okay, so the risk factor is that the patients will be on anticholinergic, or the patient will be or having some calculi, okay, some calculi, or let's say even a tumor, some obstruction, or the patient is very dehydrated. The case scenarios will be dehydration, or the post surgery patients or post intubation patients. Okay, so dehydration, post surgery, post intubation, some calculi, some obstruction, okay, that is calculi or neoplasm, okay, or your ACH. So these are all the risk factors as to why the patient is having a decreased salivary flow. Okay, why the patient is having a decreased salivary flow. So when you're having this particular case scenario, okay, like a patient with this background coming with a post auricular swelling. Okay, so a patient with this background is coming with either a pre or a post auricular swelling. And of course, they will usually have the same symptoms like, the systemic finding, fever, chills, and all that will be there. Okay, so then they will say that this swelling will be combined with two things. Okay, either they are saying about your trismus, okay, the jaw problem, okay, and your dysphagia. So they can talk about either trismus or they can talk about dysphagia. Okay, so now you need to keep in mind, when a patient is basically having a decreased salivary flow, I told you, like, till now, whatever I've seen the case scenarios on, they have given a case scenario for medication usage with anticholinergic. They have given calculi and your tumors and dehydration and your post-surgical or intubation case scenario with the patient who's coming with a pre or a post-auricular swelling and your trismus or dysphagia. You have to be thinking about your staphylococcal aureus and your anaerobes. Okay, staphylococcal aureus and anaerobes. Okay, the only way you can diagnose is that, so these patients are going to have elevated amylase, but they don't have the pancreatitis. Okay, so pancreatitis, the pancreas specific enzyme is lipase, right? So you have to remember they will have an increase in amylase, but they won't have the pancreatitis, which is one of the important finding. Okay, one of the important finding that you have to keep in mind. Okay, so your increase in your amylase without pancreatitis is your lab finding. In the CT, you can just see whether the patient is having obstruction or an inflammation, like whatever case scenario we have discussed till now. Okay, so that is how your perotitis can be like questioned. And next is pneumonia. I think secondary bacterial infection, I told you, right? Yeah, so how they will give you a case scenario of pneumonia is that they will tell you the fever, consolidation in the lung, productive cough. Okay, all of that pneumonia symptoms are going to be there. Okay, so you have to know what all are the most important secondary bacterial pneumonia causes. One of that is staphylococcal aureus, and you have to remember streptococcus pneumonia and your hemophilus influenza. Anybody who has had a primary infection with a viral. Okay, so the secondary common bacterial infection that you can have is either Staphylococcus aureus, or you can have a Streptococcus pneumoniae, or you can have a patient with Haemophilus influenza. So you have to know how to differentiate between these three only. Okay, so that's all about Staph aureus. So nothing much about that. So let's go to the next presentation where a patient is coming with Staphylococcal epidermidis. Okay, so epidermidis, as they have given, please remember that was a cocci in clusters, but it was both your, when the Staphylococcal aureus was given, I told you first it is beta hemolytic. Okay, the patients of Staphylococcal aureus is going to be beta hemolytic. They are gram positive, and they're also catalase positive and coagulase positive, but this is your coagulase negative. The catalase is positive, but the coagulase is going to be negative. Okay, so now if a patient is coming with epidermidis, okay, so how they will give you a case scenario is that, so it's the most common pathogen that's going to be seen with respect to the bloodstream infections, with respect to the nosocomial bloodstream infections. Okay, so I will make a list of that. So first is that it's novobiocin sensitive. It is novobiocin sensitive and coagulase negative and urease positive. The first difference that you have to know. Okay. So, and this will not ferment mannitol when compared to your Staphylococcal aureus, which was basically fermenting your mannitol. And this is going to be seen normally like in the flora of the skin, as you're saying. It is a normally present in the flora of the skin, and it's going to contaminate your blood cultures. So this actually has a capacity to produce adherent biofilm. Okay, this adherent biofilm, as they have given here, this production of adherent biofilm is going to infect all the prosthetic devices. So those prosthetic devices are only your hip implant, your heart valve, your IV catheters, all of these are prosthetic devices. Okay, so now most common cause of endocarditis, if you're seeing in a patient with artificial valve. Okay, so now they're having a implant or a valve, okay, and they're having an endocarditis. So then you have to think about your patient who's on Staphylococcal epidermidis. Okay, the bacteria is Staphylococcus epidermidis. Okay, so these patients, wherever the entry is, for example, IV catheters are there, no, in that area they're going to have the erythema. In that area, you're going to have erythema. So now how do we treat this whole Staphylococcal epidermidis presentation? First is, if the entire valve is itself infected, then you have to think about, replacement of the valve. But if you want to give an antibiotic for now, then you can think about vancomycin. So till now, with this presentation of Staphylococcal epidermidis, I've seen many case scenarios with a heart valve, like a new heart wall, like an artificial heart wall, and the patient is right now coming with the presentation of endocarditis. Okay, so that was the most common presentation that was asked. Okay, so now one more thing I want you guys to remember with this is that the empirical treatment of coagulase negative staphylococcal infection will always include vancomycin. Okay, because it has a very widespread MRSA, especially if it is a nosocomial infection. They will ask you why you are going for vancomycin. It is because the coagulase negative staphylococcal infections, they have a widespread possibility of MRSA in the nosocomial infections. That's why we have to go for vancomycin. Okay, so now if the patient's susceptibility is actually resulting in MRSA alone, okay, then you can like change the vancomycin to oxacillin or napcillin if you want. Okay, so whenever you think about nosocomial bloodstream infections, I want you guys to think about coagulase negative staph. I want you guys to think about coagulase negative staph and your Staphylococcal aureus and your Staphylococcal aureus and enterococci and also your Candida. Okay, so these are quite a few common pathogens, most common pathogens with respect to nosocomial bloodstream infections, coagulase negative staph and Staphylococcal aureus, enterococci and Candida. Okay, so now the next staph is, I think, saprophyticus. Yeah. So with respect to saprophyticus, apart from the fact is that it's the same. Okay, it's going to be like catalase positive, coagulase negative, urease positive. Everything is same with respect to Staphylococcus epidermidis and this. Okay, just that it's novobiocin resistant. The clue for your saprophyticus is the resistancy of the novobiocin. Okay, so now for the Staphylococcus saprophyticus, it's always like a reproductive age female. Okay, so right now she is coming with the presentation of UTI. Okay, so generally if you think about UTI, because female have short urethra, we always think like the fecal bacteria, that is your E. coli, as the most common cause. Okay, E. coli as the most common cause. But if a patient is basically coming like a reproductive age with your sexual infections, okay, so then we have to sexually active young women. Okay, so then we have to be thinking the second most common cause, which becomes the major priority in this particular case scenario, which is going to be your Staphylococcus saprophyticus. Okay, so what I'm saying is if they're just giving a UTI presentation, how will a UTI present? So any women, or I'll just keep an example as women. Okay, any woman who's coming with a presentation of fever, who's coming with a presentation of dysuria, burning micturition. Okay, so now you're taking the labs, you're seeing that the patient is actually having an increase in your WBC. Okay, so when you see this particular presentation, what you have to remember is the most common cause is going to be your E. coli. The most common cause is going to be the E. coli, but in a reproductive age woman who is sexually active, okay, so there you have to be thinking about your staphylococcal epidermidis. Okay, so sorry, saprophyticus. So I will give you a case scenario, like an example, so that you guys understand. Okay, so let's say we have a 22-year-old woman. Okay, 22-year-old woman. 22-year-old woman. She's coming to the clinic because she's having a 2-day history of urinary like burning, and there is a frequency. So the patient is coming with urinary frequency and the patient is coming with urinary burning. Okay, she's sexually active and she's having multiple partners. Okay, now she's coming with a mild suprapubic tenderness. Okay, she's coming with a presentation of mild suprapubic tenderness. Okay, so now apart from that, we checked the urine analysis. The urine analysis is showing it's nitrite negative. Nitrite is negative means it's not E. coli. Okay, and it is leukocyte esterase positive. It is leukocyte esterase positive. So now they're asking us what is the answer. So here it is going to be your Staphylococcus saprophyticus. So this is just a case scenario of dysuria and urine frequency, which is basically a cystitis presentation. Okay, because they're saying leukocyte esterase positivity is there, it's telling us that okay, WBC is actually present. Okay, so generally it's E. coli, but here it's reproductive sex women, so you have to choose your Staphylococcus saprophyticus. Okay, even Klebsiella pneumoniae is also one of the cause for your UTI or cystitis, but you have to remember both of them are going to be nitrite positive in the urine analysis. So the differentiation is that both your E. coli and your Klebsiella pneumoniae, which is your common causes of cystitis, is going to be nitrite positive in the urine analysis. It's going to be nitrite positive in the urine analysis. Okay, so we'll go to the next concept. Okay, so next is your strep pneumoniae. Okay, so before going to strep pneumoniae, one second, I'll just look if there's anything else I can give you case scenarios with respect to staph. Okay, I haven't discussed one questions about enzymes, right? So we'll do one question about enzymes. Okay, so let's say we have a micro lab, okay, and we are trying to investigate all the possibility of how to use an enzyme. Okay, so now what they're saying is they're saying that the enzyme basically functions by destabilizing the bacterial cell wall. Okay, so it is destabilizing your bacterial cell wall. All the clue is that there is a micro lab. Okay, they're trying to investigate the usage of the enzyme. The enzyme is basically functioning by destabilizing your bacterial cell wall. Okay, but they are saying that it cannot traverse your bilipid membrane. It cannot traverse your bilipid membrane. So now the question is, which organism do you think is going to be affected by this kind of drug? Which organism is going to be affected by this kind of drug? Okay, so now here is a case scenario that only the bacterial cell wall can be destabilized. Okay, that is going to be happening only in a gram positive bacteria. So now any gram positive bacteria you can think about, like for example, Staphylococcus aureus. Okay, so that is because in a gram negative bacteria, they're going to have like a outer lipid bilayer. Okay, if you remember the previous class of basic bacteriology, I told you that in a gram positive, they're going to have cytoplasmic membrane. The gram positive and the negative, both of the patients are going to have cytoplasmic membrane. Okay, both the patients, after the cytoplasmic membrane, what happens is that they're going to have the peptidoglycan. Okay, the peptidoglycan. Okay, and then you're going to have the cell wall, and then you're going to have the cell wall, but just a little bit difference in your gram negative. Okay, they're also going to have the peptidoglycan and they're also going to have the cell wall, but the extra is that they are going to have this LPS or your endotoxin, and they're going to have the porin. Okay, they're going to have like a outer membrane lipid bilayer. Okay, outer membrane lipid bilayer. Okay, so now they are saying that this drug is not traversing through the bilipid membrane or the lipid bilayer, so it's not a gram negative bacteria. they can ask you a case scenario like this of a gram positive bacteria, just a drug working on them, and they can ask you like what is the most common organism. Okay, so now let's say one more case scenario. A patient is around 70-year-old woman. Okay, so she is coming to the emergency department with 1 day of acute onset knee pain, acute onset left knee pain. Okay, so she's basically having 1 day of acute onset of left knee pain. So now she recently went for an arthroplasty. She recently went for an arthroplasty because like done 2 weeks ago. And now she's coming with like a fever of 100 degrees Celsius. She's coming with a swelling. She's coming with an erythema. She's coming with a decreased range of motion. Okay. She's also coming, that is happening in the same knee only. And she's also coming with a WBC finding of around 62K of WBC. Okay. And the culture is also that's grown in the case scenario was Staphylococcus aureus. Okay, so now they have given you a case scenario where a patient went for arthroplasty around 2 weeks ago, and right now she's presenting with all the fever, the increase in leukocytes, and your entire presentation of the same. So now they're asking, what is the disorder? Why is a patient having this much of increase in your leukocyte count? Okay, so now here what we have to understand is the patient is coming with gout. Okay, so you have to know that gout, we know it's gout only because of the WBC value, it's so high. Okay, so I want you guys to remember what the differences in the WBC value. Okay, if it is a patient of less than 2000 of WBC, the most common causes are going to be your trauma or your osteoarthritis kind of related. Okay, if it is more than 2000, okay, when I'm saying 2000 per millimeter cube, okay, 2000 per millimeter cube, if it is going to be more than 2000, you should think about inflammatory arthritis. Inflammatory arthritis can either be your rheumatoid arthritis, or it can be your gout, or it can be your pseudo gout, or it can also be your prosthetic joint. Okay, your prosthetic joint related infections, or it can also be your septic arthritis. Okay, but that all of them are going to be more than 2000 for sure. Okay, for more than 20,000, for more than 20,000, it is again gout, pseudo gout. Okay, and your prosthetic infection and your septic arthritis. So it's better to remember the entire gout, pseudo gout, your septic arthritis, prosthetic as more than 20K. For more than 2000, just remember rheumatoid arthritis, like an inflammatory arthritis. Okay, so because I gave you a 62,000 of your leukocyte increase, you have to remember that that's going to happen only with your prosthetic joints. Okay, so now here I told you that the patient was actually having a fever. Okay, and the patient is having a staphylococcal aureus. Okay, so the prosthetic joint infection is usually seen in the first 90 days, like 3 months of the surgery. Okay, so staphylococcal aureus is a very important cause of prosthetic joint infection, and here because the WBC was more than 2000, like 20,000. Okay, so here, even with septic arthritis, it can go above 50,000 itself. Okay, so and especially in a gout kind of presentation, they're going to have approximately 20,000 and above, and pseudo gout is also 20,000 and above. So here is a prosthetic joint infection, okay, which can be similar to a case scenario of gout, and a case scenario of pseudo gout, and a case scenario of your septic arthritis. Okay, so now here you can just stick to the patient is having like a prosthetic joint infection, which can be seen with all of these four presentation. So maybe if the patient had a extra podagra, it is a for sure gout. Okay, so maybe if the patient had uric acid crystals, it's a for sure gout. If a patient had an extra calcium pyrophosphate deposition, okay, then it's a for sure pseudo. Okay, so if it's a patient who's coming with a septic arthritis, you do know that they will have like an entire hemodynamic instability also. Okay, so we'll go to the next case scenario with respect to Staphylococcus aureus. Okay, so let's say we have a patient. Okay, so now he is around 60-year-old. Okay, 60-year-old man. He is coming because he's at 1 week he's been having like so much of pain and swelling in one big toe. Okay, so the right big toe, he's having so much of pain and so much of swelling. Okay, so right now he's working as a construction worker. He's working as a construction worker, and the next clue is that he's very worried that if this pain is going to affect the ability of him doing the job. Okay, so now the physical examination is done, and the patient is having erythema, the patient is having swelling all in the same nail fold. Okay, the patient is having erythema and the swelling in the nail fold. Okay, so and it's also the patient is having this whole presentation in the proximal nail fold, and there is also fluctuance that is seen underlying the lateral fold. Okay, there is also fluctuance that you can notice underlying the lateral fold. Okay, the nail plate is intact, just there is a swelling. So now they're asking you what is the diagnosis in this particular case scenario. This is a case scenario where a patient is coming with edema, erythema, okay, and fluctuant mass in the nail fold, okay. So because I'm saying that this person is a construction worker and he's been having this as a local skin flora, you have to think about the local skin flora is always Staphylococcus aureus or Streptococcus pyogenes. Okay, so less than 6 weeks, 6 weeks means you have to remember it's going to be your acute paronychia. Acute paronychia is nothing but an infection of the nail fold, which is going to like usually present as a swelling or an abscess, okay, which is usually isolated for a single digit. Here you have to think about again your Staphylococcus aureus. Okay, another way of asking this, I just thought paronychia is not given as infection in a particular in the book, so that you have to know. Okay, so we'll go for one last question of Staphylococcus aureus, then I will go for strep. Okay, so let's say we have a patient who's around 60 years old. This time let's keep a woman. She's coming with a 5-day history of, let's say, fever. She's having a difficulty of breathing. She's having a productive cough. Okay, so she's also having muscle ache. Okay, she's also having muscle ache. So general presentation. So now she is saying that she recently recovered from a flu. She recently recovered from a flu. Right now, her temperature is around 101 degrees Fahrenheit, and the respirations are around 25 per minute. The respirations are 25 per minute. Okay. So now I took a chest X-ray. It is showing that there is patchy infiltrates. There are patchy infiltrates that is present in the middle lobe of the right lung. Okay, just patchy infiltrates are present. Okay, so now I'm taking the gram stain. The patient is now coming with a gram stain presentation. So now they're asking what is the virulence factor or what is the characteristic of the casual organism. Okay, so gram stain, it is a gram positive organism, which is a cocci and which is basically in clusters. I have given you around 4 clues, but this much of clue they won't give you. They will just give you like, fever, cough, difficulty of breathing, and maybe they will mention about some extra two other diversions, and they will talk about the flu in the patient. Okay, and maybe they can give you about the patchy infiltrates, or they can give you about the gram positive cocci. But irrespective of it, what you have to understand is if they had giving you the third clue, after a viral infection, your secondary added bacterial infection, one of the causes Staphylococcus aureus, the patient's patchy infiltration is lobar pneumonia. Okay, so the virulence factor or the characteristic that you have to know is protein A. So just now we discussed about the protein A, right? That is also one way of asking. Or they can ask you like the exotoxin is going to go, the staphylococcal skin scalded syndrome or staphylococcal scalded skin syndrome. They can ask you like the exotoxin is going to go and bind to which of the following structures like desmosomes. Okay, so that is about all together with respect to staphylococcal aureus. So let's move on to the next organism, that is streptococci. Okay, so Streptococci, how do we identify? Okay, so it is first catalase negative. The catalase positive was staphylococci, right? So catalase negative is streptococci. Again, we were dividing them into gamma hemolytic, beta hemolytic, and alpha hemolytic. Alpha is partial green color, and beta hemolytic is complete hemolysis. Okay, and the gamma has no hemolysis. Okay, so you have to remember that. Okay, if it is going to be, I will just give you a easier way, like how I remember. So starting with streptococci, all of them are going to be catalase negative. So then divide them into three parts: alpha hemolytic and beta hemolytic and your gamma hemolytic. Alpha is partial, beta is complete, gamma is no hemolysis. Okay. So if it is going to be either optokin resistant or optokin sensitive. Okay. And the same way you have to remember bile insoluble, optokin resistant and bile insoluble, or your optokin sensitive and bile soluble. Okay, bile insoluble and bile soluble. Next is your beta hemolytic. Beta hemolytic, you have to remember whether it is bacitracin sensitive or bacitracin. So you have to remember if your beta hemolytic is bacitracin sensitive, and if it is going to be, one second, I'll write it together. If it is bacitracin sensitive, and if it is going to be your PYR positive, okay, or is it your CAMP positive plus your PYR negative. Okay, so now I will tell you examples for these four organisms first. Okay, so now if it is a patient of alpha hemolytic, optokin resistant, bile insolubility, it's going to be your Streptococcus viridans. It's going to be your Streptococcus viridans. If it is your alpha hemolytic, optokin sensitive, okay, but it is going to be your bile solubility, it is Streptococcus pneumonia. It is Streptococcus pneumonia. Okay, so now if it is beta hemolytic, PYR positive, bacitracin sensitive, then you have to remember it is Streptococcus pyogenes, group A. Okay, group A Streptococci. If it is PYR negative but it is CAMP positive, then it is Streptococcus agalactiaceae. It is Streptococcus agalactiaceae. Okay, that is group B Streptococci. This is group A. So okay, the pyogenes is group A Streptococci. This is group B Streptococci. Okay, so next is gamma hemolytic. Gamma hemolytic, you have to check whether it is growing in the bile, okay, whether it is growing in the bile, and whether it is PYR positive, okay, whether it is growing in the NaCl, okay, and then you have to see one more category is it's not growing in the bile or it's not growing in the NaCl of 6.5%, plus the organism is PYR negative. So this is going to be your enterococci, this is going to be your enterococci, and this is going to be your Streptococcus bovis. This is going to be Streptococcus bovis. Okay, so now you have had the entire catalase negative divided into alpha, beta, gamma. Alpha is partial green color, beta is complete hemolysis, gamma is no hemolysis. Optokins resistant and bile insoluble is viridins, optokins sensitive and bile soluble is Streptococcus pneumoniae. PYR positive and becitracin sensitive is going to be Streptococcus pyogenes, also known as your group A Streptococci. PYR negative CAMP positive. Mainly the CAMP positive means group A Streptococci. If it is growing and it's PYR positive, it is going to be enterococci. Not growing and PYR negative Streptococci bovis. Okay. So now you have to know how to differentiate with respect to all these 6 organisms. Okay. So I will tell you in an easier way, just like what is the usual presentation they will give in the examinations. Okay, if it is a case scenario of viridins, okay, they will try to give you like a dental carie kind of patient. Okay, the patient will have dental caries, the patient will have like a SBE after the dental work. Okay, they will have a SBE after the subacute bacterial endocarditis. Okay, subacute bacterial endocarditis, dental caries kind of presentation. If they are giving you a Streptococcus pneumoniae, they will give you a presentation of the same pneumonia can be there. Okay, pneumonia can be there. Okay, the patient can have meningitis, the patient can have otitis media, and the patient can have sinusitis. Okay, the easier way to remember this is your lungs, ear, and brain. Okay, easier way to remember this is lungs, ear, and brain. Okay, so sinusitis, meningitis, pneumonia. Okay, and your otitis media. So next is if they're giving you a case scenario of Streptococcus pyogenes, okay, then it is usually cellulitis, your pharyngitis, and your erysipelas. Okay, erysipelas, if it is pyogenes. If it is going to be agalactiaceae is going to be a patient who's coming with neonatal sepsis, and they can give you a pneumonia, meningitis presentation and a UTI. So that's why pneumonia and meningitis is seen with both your Streptococcus pneumonia, which is basically alpha hemolytic, and it is also going to be seen with your Streptococcus agalactiaceae, which is your beta hemolytic. That is a patient who's coming with agalactiaceae. Okay. So next is your gamma hemolytic presentations of enterococci. Enterococci, they will always come with a patient of your infective endocarditis after seen with your GI procedures. Okay. Or they can have a presentation of UTI. Okay. So now UTI is seen with agalactiaceae and your enterococci. Enterococci is gamma hemolysis, and your UTI with your agalactiaceae is going to be beta hemolysis. Okay, so next they can also have wound infection as a very common case scenario. Wound infections. Okay, so the next organism is Streptococcus bovis. Bovis, they will give you a presentation of either a bacteremia or infective endocarditis. So I'll just put it as infective endocarditis, but after the colon cancer. Okay, these are the most common presentations that they try to give. Okay, you have to know how to differentiate these 6 presentations with respect to your streptococci. Okay, so now let's go in detail about them, starting with your streptococcal pneumonia. We've already studied about streptococcal pneumonia with respect to your vaccinations. I've told you that if a patient is basically on your pneumococcal polysaccharide vaccine PPV23, and I also told you pneumococcal capsular vaccine PCV7. Okay, so now that is the 2 vaccination that is given in the adult and the pediatric population. So I'll go and show you that. Okay, the vaccinations are not given here, but what I expect you guys to know is when we have discussed before itself with respect to your conjugate vaccinations, I would have mentioned over there. Okay, so now let's discuss about like what is the case scenario of Streptococcus pneumonia. I'll give you a few case scenarios, even with your Streptococcus pneumonia, Streptococcus pyogenes, your viridans group of Streptococci, okay, and also your bovis and agalactaceae. Okay, let's cover all Streptococci together. So now first case scenario, let's say we have a patient of 10-year-old girl. Okay, she's coming to the physician because 2 days she's been having a rash. For the last 2 days, she's been having this presentation of rash. Okay, the patient mother says that 1 week ago, the daughter was having a severe sore throat. Okay, 1 week ago. Okay, just 1 week ago, the patient was having a sore throat. Okay, and the patient was also having a fever approximately of 1 or 2 degrees. So this 1 week ago, sore throat and fever of 1 or 2 degrees. Right now, the patient's presentation is the same. The rash is there. Okay, this rash is there, plus the petechiae and the punctuate red macules are also there. Okay, so first the patient is having erythematous tonsils, let's say, and the patient is also having like petechiae, which is very small. Okay, the patient is also having like red macules. The patient is having red macules. Okay, so this is basically present in the hard and the soft palate, and it's also presenting with a very bright red tongue. Okay, the patient is coming with the presentation of bright red tongue. Okay, so now this is a clue. 10-year-old girl coming with a rash after before the patient was actually having a sore throat and a fever. Okay, right now this is a presentation. They're asking what is the pathogen or what is the causative agent for this kind of presentation. Here it is a scarlet fever that is seen in a younger individual of Streptococcus pyogenes. Okay, so why am I saying it's a scarlet fever? The recent sore throat. Okay, the recent sore throat. The scar latiniform rash. Okay, the whole rash is called a scar latiniform rash. Okay, the red and bumpy tongue. The red and bumpy tongue. It's called a strawberry tongue. Even though strawberry tongue is a very common presentation or word used for Kawasaki's, you have to remember strawberry tongue is used here also. Okay, so now they're also having this rash that I told you. Know all that is towards scarlet fever. So let's go to Streptococcus pyogenes. Yeah. So now you have to remember that Streptococcus pyogenes, your toxigenic presentation is your scarlet fever. Okay, this rash is like a diffuse erythema. So how will you remember this particular rash is that they are going to present as a very diffuse erythema. So it will present as a diffuse erythema. Next is that you have to know it will blanch with pressure. It will blanch with pressure. Okay, they are basically around 1 to 2 millimeter. They are basically around 1 to 2 millimeter, and they're going to be there like a sandpaper quality to the skin is going to be there, like a 1 to 2 millimeter papular elevation with a sandpaper quality. You have to remember, I told you an example of strawberry tongue. I told you that the patient is going to come with a sore throat, that is pharyngitis. Okay, scarlet fever is a complication of Streptococcus pyogenes infection. One of the complication seen along with the pyogenes, another complication you can have is your, just now we did your PIGN. Okay, the PIGN patient can have your streptococcal pyogenes as your post streptococcal glomerulonephritis also. Okay, so this is one case scenario. So let's go to one more case. Next is, let's say we have a teenage patient or a patient before the college time. Okay, so let's keep 17-year-old female. Okay, so she is right now coming with pain that was presented in the right ear. Okay, she's having pain in the right ear, and she's a very avid swimmer. She's a very avid swimmer. Okay, apart from this, the clues that is given is that the patient's temperature is 101 degrees. Okay, the same area where they're examining, the right ear, there is pain, there is warmth, there is tenderness, there is erythematous lesion that is seen. Okay, just a patient who's coming with warmth and tenderness and erythematous presentation. So now they're trying to look at the right tympanic membrane, but the right tympanic membrane is not visualized at all because of the pain. So now they're asking us what is the reason of this, like what is the, why is the patient having this? So here the answer is going to be Pseudomonas aeruginosa. Okay, here the answer is going to be Pseudomonas aeruginosa. So why I took this concept out is because, see, with respect to Streptococcus pyogenes, okay, so you will see that Streptococcus pyogenes can cause otitis media. Okay, Streptococcus pyogenes can cause your otitis media. Okay, and even your Haemophilus influenza can cause otitis media. Even your Moraxella will cause your otitis media. Even your Streptococcus pneumoniae can cause otitis media. I'll tell you all the organisms for otitis media. Otitis, this case scenario, I'm not saying it is otitis media, but I'm saying otitis media organisms are Haemophilus influenza, your Moraxella, and your Streptococci pneumoniae, and your Streptococci pyogenes. But this patient is a otitis externa. Okay, this patient is a otitis externa. Okay, so that is usually seen after your staphylococcal aureus, or it's seen after your the patient's right now cause of otitis externa is basically pseudomonas. It's basically pseudomonas because they've also given a clue that the patient is an avid swimmer. Okay, so now I'll show you. You can mark that concept with respect to a patient. Yeah, I want you guys to remember this. The difference is that your pseudomonas in otitis externa, they've given swimmers here. So that is a very important clue. Okay, so otitis externa is often associated with your swimming, and it's going to be presenting like a pain with pruritus and discharge. Okay, and when you manipulate the pinna, like just pull the pinna itself, they will have so much of pain. Okay, they are going to be like leading to osteomyelitis. So this otitis externa can lead to osteomyelitis also. Okay, which is affecting all the bone of the skull, the cranial nerve damage, all of that is going to be seen. So this is one of the different presentation. Like you have to know how to differentiate otitis externa and otitis media. Okay, so now I'll give you one more streptococci case. Streptococcus will only cause otitis media, not the externa. Okay, so next is, let's say we have a 30-year-old woman. Okay, let's say we have a 30-year-old woman. Okay, she is coming to the clinic because she's feeling under the weather. Okay, her complaint is that she's feeling under the weather. That's all she's saying. Okay, and this has been there for the past 2 weeks. Okay, so she has a history of mitral wall prolapse. She has a history of mitral regurgitation. She has a history of oral surgery all 2 weeks ago. Okay, all are 2 weeks ago. Right now, her temperature is given that it's 101 degrees Fahrenheit. Okay, and the patient is also having like around 1 to 2 millimeter of purple lesion that is seen in the leg. Okay, so purple lesion seen in the leg. Okay, 30-year-old female coming with under the weather presentation for 2 weeks. She's having a history of your MVP or mitral wall prolapse or your mitral regurgitation and your oral surgery 2 weeks ago. So right now her temperature is 101 and she's also having purple red lesions on the legs and the feet, and the patient's fundoscopy is also showing Roth spots. Okay, the patient's fundoscopy is also showing it is Roth spots. So here is a case scenario of an infective endocarditis. So because we have to understand infective endocarditis with respect to oral lesions, I told you it's viridans streptococci, right? So streptococci viridans, there are actually four organisms with streptococci viridans. Okay, so with respect to Streptococci viridans, there are four organisms. So one is your mutans, another is your sanguinis, another is your oralis and mitis. One more thing, remember it is oralis. Okay, Streptococci viridans, which is basically a gram-positive alpha hemolytic optokin resistant bile insoluble bacteria, which is usually seen in the oral cavity. What you have to know is this kind of presentation has four bacteria: mutans, sanguinis, oralis, mitis. So now they will ask you what is the common cause of infective endocarditis with respect to your Streptococci viridans. You have to remember it is sanguinis. Okay, you have to remember it's going to be sanguinis. Okay, so your sanguinis is the option that you have to choose here. And you should also know that infective endocarditis can be with a lot of bacteria. I'm dumbing down or narrowing it down to your viridans because of dental procedure, because of the oral surgery that the patient actually went to. Okay, so now let's go for one more case scenarios. Like I'll discuss around like 10 cases. Okay, then I will go about the theory aspect of it. Okay, so let's say a patient is coming. Okay, let's keep 10-year-old boy. Okay, so 10-year-old boy, he is coming to the pediatrician because he's been having this fever and difficulty swallowing and sore throat. Okay, so the presentation is fever, he's having dysphagia, difficulty in swallowing, and he's having a sore throat. Okay, so right now he has received all the immunizations, meaning they're trying to say that the patient is not seen with your Haemophilus influenza as a cause scenario. Okay, so immunizations are all done. His temperature is around 102 degrees Fahrenheit. Okay, physical examination was done. He's having a purulent tonsils. Okay, tonsillar exudates. Okay, the patients are having purulent tonsillar exudates. Okay, and the patients are also having anterior cervical lymph nodes. The patients are also having anterior cervical lymph nodes. Okay, the bacterial culture for the same tonsillar exudate and the microscopy analysis is showing that it's a gram-positive bacteria. That's all. Gram-positive cocci. That is the only clue they're trying to tell you. Okay, so now you have to know what is the organism and what is the characteristic of the organism. Okay, so here I gave you a case of fever, sore throat, anterior cervical lymphadenopathy with a tonsillar exudate, which is basically a gram-positive cocci. Okay, it is a streptococcal pharyngitis. So now why am I saying it's streptococcal pharyngitis? Because we do know sore throat here with respect to the purulent exudate is basically pharyngitis. Okay, so maybe if you can go ahead and do a throat swab culture, or if you do a rapid strep test, you can go and diagnose and confirm it also. Okay, so now what is the characteristic of the streptococci? So here the characteristic of your streptococci, group A streptococci pyogenes, is that they are going to be seen as a gram positive organism, catalase negative organism, beta hemolytic organism, and bacitracin sensitive organism. Okay, so just I gave you a case scenario of a patient who's coming with your pharyngitis. Okay, so now catalase, why one more thing I want to say is that catalase is an enzyme that's going to break down your hydrogen peroxide into water. Okay, if you remember the yesterday's class, catalase is an enzyme that will break down your hydrogen peroxide into water. Okay, so they can ask you like what is catalase negative meaning, what is coagulase negative meaning of it. Okay, so now here the antibiotic that we can go ahead, okay, because it's a beta hemolysis, that means you are having a complete lysis of your RBC, okay, in the media that you can see. Okay, so this lysis is actually because of the streptolysin exotoxin. So this lysis is because of the streptolysin exotoxin. So bacitracin is the antibiotic that you can commonly use to characterize these particular bacterial strains. Okay, so let's go to one more case scenario. So here we are having, let's say, another 10-year-old male. Okay, but this time this 10-year-old male, he is coming with a presentation of blister and rash in the buttocks. Okay, so 10-year-old male, he is having a blister and he is having a rash, okay, which is seen in the buttocks. So right now, what is important is that they are also seeing that two fluid-filled blisters are seen like a couple of days ago, and it's very ruptured easily. Okay, so this kind of blisters, okay, it was seen like a couple of days ago, and it has ruptured. Okay, so right now, after the physical examination was done, I can see some bullae, and I can also see some honey-colored crust. Okay, I can also see some honey-colored crust. So now we are asking what is the bacteria, what is the toxin of it? Okay, what is the bacteria and what is the toxin? So here what we have to understand is they're given us a presentation of bullous impetigo. Okay, a bullous impetigo where they're having fluid-filled vesicles, they're having it rupture very easily. Okay, they're leaving like a honey-colored crust, okay, on the skin surface, and the patient is also very young, right? So bullous impetigo is kind of common in the younger children. Okay, so bullous impetigo, which is usually seen with your staphylococcal aureus, we've already done this. It's going to be your exfoliative toxin A. Okay, exfoliative toxin A. It is a bullous impetigo of a presentation of staphylococcal aureus. Okay, this kind of exotoxin is also going to be the reason of staphylococcal scalded skin syndrome. Okay, which is basically against your desmoglein. Okay, so you have to remember bullous impetigo, presentation of exfoliative toxin A, which is coming from the staphylococcal aureus. Okay, so I'll go for one more case scenario. Let's say this time we are having a patient who is 8-year-old boy, and he's coming to the pediatrician because he's having pain and swelling in the joint. Okay, so now it is big, it's starting in the left knee, the pain and swelling is starting in the left knee, and then it is going to the left hip. Okay, and then it's going to the right shoulder. So what they're trying to say is a migratory polyarthritis. Okay, so migratory polyarthritis in a very small boy, like around 8 to 10 years. Okay, 8 to 10 years boy, what will I think? I will think about rheumatic fever, right? So the findings are also very supportive of it. They're saying that there is a holosystolic murmur. They're saying that their patient is having subcutaneous nodules. Okay, so now the question is, what is the causative organism and what is the mechanism as to how they're having this particular presentation? Okay, so now with rheumatic fever, okay, with rheumatic fever, it's again your Streptococcus pyogenes only. So what you have to know is that they are going to be having a cross reactivity between the antibodies, and that's going to be against your foreign and the host antigen. To put it in a simpler way, okay, so there is a host and there is a streptococcus pyogenes bacteria. Okay, so now the streptococcus pyogenes bacteria, which is group A streptococci, they're going to have a virulence factor that's called as M protein. Okay, they're going to have the virulence factor that's called as M protein. So this M protein has a molecular mimicry. Okay, it is very same with respect to the tissues that is present in our body. Okay, this M protein is mimicking the tissue that is there in the body. Okay, so now what happens is that the antibodies which is targeting your M protein, unknowingly they're thinking that this is very similar, right? The M protein and the host tissue, they're targeting the host also. So this concept is called as your molecular mimicry. This concept is called as molecular mimicry, that what is happening in your rheumatic fever and how they're presenting with, the presentations of Sydenham chorea, the presentation of subcutaneous nodules, the presentation of erythema marginatum, the five criterias, okay, the five criterias of your rheumatic or with the Streptococcus pyogenes is going to be a patient who's having a migratory polyarthritis, usually seen in a very young boy, okay, young age. And the patients are going to be coming with the presentation of your carditis, and the patients are going to have subcutaneous nodules, and the patients will have erythema marginatum and Sydenham's chorea. So what is your subcutaneous nodules? These are seen in the bony prominences. Erythema marginatum, Sydenham's chorea is nothing but involuntary and purposeless movements. You'll be learning about this in your CVS anyway, but I just want you guys to know that Streptococcus pharyngitis presentation after 2 weeks, 2 to 6 weeks, they're going to have this whole presentation of rheumatic fever also. You can check the titer of anti-streptolizin O. You can say that it's going to be elevated. So now here the mechanism is molecular mimicry, and the patient is having a Streptococcus pyogenes, group A streptococci causing the particular infection. Okay, so now let's go to the theory of all the streptococci together. So streptococci, what you have to take away, it's a gram-positive bacteria. It is a diplococci. Okay, so strep pneumoniae, first you have to remember it's gram-positive, then you have to remember it's diplococci. Okay, so now you have to know that the patient's virulent, okay, so they have no virulence if they don't have the capsule, because the whole capsule as well is a virulent factor. Okay, so the capsule is a very important virulent factor. Okay, so polysaccharide capsule. Next is they have IgA protease. They have IgA protease as one of the virulence factor. So next is they have pneumolysine O. Okay, what is your IgA protease important? IgA, if it is not there, we did a question also for that. They are going to cause invasion and colonization of the mucosa. Okay, if IgA protease, if it's going to be broken down, it can invade your mucosa. Okay, so now next is pneumolysine O. Okay, next is your peptidoglycan and your teichoic acids. Okay, peptidoglycan and teichoic acids. They are the virulence factor for meningitis. They are the virulence factor for meningitis. Okay, Streptococcus pneumoniae, if it's an adult, it's going to be meningitis. If it's a child, it's going to be otitis media. Okay, if it is a patient who's coming with a rusty colored sputum, okay, pneumonia with the presentation of rusty colored sputum, I'm going to think about your bacterial pneumonia causes Streptococcus pneumoniae. They can also cause sepsis. Okay, they are given sinusitis, but I want you guys to remember one more thing. Before writing sepsis, remember all of these: polysaccharide capsule, IgA protease, and they're going to have pneumolysine O, and they have peptidoglycan and teichoic acid, which is causing virulence in your, that can cause virulence in your meningitis. Okay, and you have to know meningitis is an adult patient. Your otitis media is basically children, and they have two more concepts: pneumonia, which is usually rusty colored sputum, and your sinusitis plus sepsis. So sepsis is quite commonly seen in a patient who is having hyposplenia or asplenia or sickle cell disease. Okay, so basically the encapsulated organism I told you, right, with respect to asplenia. And the vaccinations is basically pneumococcal polysaccharide vaccine. That's a 23 valent vaccine. Okay, it's a T cell independent vaccine. It's a T cell independent vaccine, which is basically IgM only. Okay, your pneumococcal polysaccharide vaccine, which is a 23 valent vaccine. It's a T cell independent vaccine. It's IgM only. We have this given for the adults. We have this given for the adults. Okay. For the pediatric population, we have a pneumococcal capsular vaccine, which is basically a 7 valent conjugated to the protein, and it is a T cell response, and it is IgG. Okay, every word is important. Pneumococcal polysaccharide vaccine, 23 valent polysaccharide T cell independent, IgM only is adult. Okay, pediatric is going to be pneumococcal capsular vaccine, 7 valent conjugated to the protein, and T cell response, and IgG is going to be the pediatric population. This is your Streptococcus pneumoniae. So now coming down to viridans. Viridans, apart from the characteristics, what I want you guys to remember is the differentiation is that it's resistant to optokine. Okay, so because the alpha hemolytic and your optokine sensitive is what is going to be your Streptococcus pneumoniae. Okay, the viridans, they actually live in the mouth, okay, because they are not afraid of the chin. Okay, I want you guys to remember they are not afraid of the chin as a mnemonic, so they live in the mouth. Okay, but the major virulence factor is that they can produce biofilm, and this biofilm can go and adhere to the tooth enamel and to the fibrin platelet aggregations are going to be seen. Okay, the biofilm is what is you have to remember. They have biofilm production, the virulence, okay, and that is going to adhere to the tooth enamel, that's going to adhere to the tooth enamel, and it's also going to be having like a fibrin platelet aggregates. Okay, these fibrin platelet aggregates, it's going to go and damage the heart wall. Okay, it's going to go and damage your heart wall. Okay, because they're going to produce like a very insoluble polysaccharide. That insoluble polysaccharide is only your dextrans. Okay, so this biofilm production, which can adhere to the tooth enamel and which can adhere to the fibrin platelet aggregates, which is going to go to the damaged heart wall. Okay, to be very more specific, it is going to the damaged heart wall. Okay, and the patients are going to produce a insoluble extracellular polysaccharide, that is your dextrans. Okay, and that is going to use your sucrose as a substrate. Okay, these dextrans use sucrose as a substrate. Okay, they're going to use a sucrose as a substrate. Okay, so that is a virulence factor. So now what diseases you have to remember? So there are two concepts, either dental caries or subacute bacterial endocarditis, I told you. So if it is going to be subacute bacterial endocarditis in a damaged heart wall, okay, then it is going to be sanguinous. Damaged heart wall with sanguinous. Okay, they're going to make the dextrins and they're going to bind to the fibrin platelet aggregates on the damaged heart walls. If it is going to be a mutants or your mites is going to be your dental caries. Okay, they are the normal flora that we see in the oropharynx, and the biofilms are going to form plaque. They form plaque. Okay, that's about your viridins. So now coming to the pyogenes. So pyogenes, we saw like few concepts with respect to that. It's a gram-positive foci in chains, and it's catalase negative, of course, and it's beta hemolytic. Okay, but it is going to be your pyrrolidinal. Okay, pyrrolidinal, and your aryl amidase. Okay, that's called as your PYR positive. The full form of that is, okay, they've given you here. Okay, you don't have to write. So it is your pyrrolidonyl aryl amidase, which is going to be your PYR positive. This is how you compare this with your enterococci and this with your streptococci. Bovis also, because it's going to help you in differentiating. Okay, you can compare this, and it is Bessitous and sensitive. So what you have to remember with your group A streptococci is that the virulence factor. So one it has is your M protein. M protein, I told you that it's the main virulence factor. I like how you're having molecular mimicry and it can cause you rheumatic fever. Okay, so next is we have a capsule, hyaluronic acid capsule. Hyaluronic acid capsule is important because it inhibits the phagocytosis. It inhibits the phagocytosis, and it is non-immunogenic. It's non-immunogenic when you compare that with the other presentations. Okay, it is non-immunogenic because your streptolysin O and your streptolysin O is immunogenic. It's immunogenic, and it's going to lyse both the RBC and the polymorphonuclear cells. So both your streptolysin O and your streptolysin S, okay, both your streptolysin O and streptolysin S, okay, both are going to be lysing or breaking down your RBC, and they're going to lyse your polymorphonuclear cells. Okay, so now the first virulence factor is going to be M protein. That's the main virulence factor. That is your molecular mimicry concept of rheumatic fever. Okay, it inhibits obviously the complement fixation or activation and your phagocytosis. Okay, so the next concept is your hyaluronic acid capsule. That's going to be non-immunogenic, and it inhibits the phagocytosis. Okay, it's non-immunogenic and it inhibits the phagocytosis. So next is your streptolysin O. So that is going to be immunogenic. Streptolysin S is non-immunogenic. The two non-immunogenic is going to be your capsule and the streptolysin S. Okay, and the immunogenic is going to be streptolysin O. But both the streptolysin O and S, they're going to lyse your RBC and polymorphonuclear cells. Okay, so this is the evasion process. Okay, how they are evading, how they are invading. You have to remember two virulence factors extra. One is going to be streptokinase. Okay, another is your streptodornose. Streptodornase is nothing but a DNase. It's nothing but a DNase, and streptokinase is known to dissolve a clot. It's known to dissolve a clot. So this is basically the invasion virulence factor. Okay, this is for dissolve the clot. Like it converts the plasminogen to plasmin, and then you're going to have plasmin being fibrinolytic. Plasminogen is going to become plasmin, and the plasmin is going to be fibrinolytic. That's why it's dissolving the clot. Okay, so the DNase is going to degrade your DNA. That's it. It's going to degrade your DNA, so that when it's degrading the DNA, no, it can facilitate the spread of the organism. So that's about your invasion. So these are invasion virulent factors. Evasion was only your M protein, hyaluronic acid capsule, your streptolizin O, streptolizin S. Invasion is this. So now how are they going to go and like attach? Adhesion. Adhesion virulence factor is protein F. Like how there's a protein A there, here it is a protein F. Okay. So after this only you have to know about the exotoxins. The exotoxins causing your necrotizing fasciitis, you're causing your TSLS also. Okay. So I will highlight that. 1 second. Yeah. So the exotoxins that for your Streptococcus pyogenes, what you have to take away is spec A, spec B, and spec C. Okay. So the spec A and C is known to cause your TSLS. Okay, TSLS, spec A and C. Spec B is known to cause your necrotizing fasciitis. Okay, that's all is the virulent factor. Okay, that's all is your virulent factor. So now I want you guys to remember so many lesions are there with respect to your Streptococcus pyogenes. Okay, because they are pyogenic, they have given you exactly what you have to know. Okay, the pyogenic is pharyngitis, cellulitis, impetigo. So we saw a case scenario of impetigo where they are coming with like, honey crusting presentation, honey crusted lesions. That is how impetigo is going to be. Impetigo, if you're thinking about non-bullous impetigo also, who has a non-itchy pustule and a honey crusted lesion, they're going to have antibiotics like mupirocin being used. And the complication is that after the impetigo, they can have a post-infectious glomerulonephritis. Okay, that is one presentation. Your impetigo is caused by Staphylococcus more commonly and Streptococcus pyogenes of group A less commonly. Okay, but if they're having impetigo, you have to think about Staphylococcus aureus is the first option. Okay, after that only your group A is Streptococci, that is your beta hemolytic. Okay, so next is the presentation of your toxigenic scarlet fever. We saw case scenario, blanching, sandpaper like quality, strawberry tongue, erythrogenic toxin. So these are all the clue words that you have to know. Next is immunologic. One case scenario is rheumatic fever, where I told you the patients will have the John's criteria, that polyarthritis, colitis, nodules, erythema marginatum, Sydenham's chorea, and they will have a pharyngitis. But you have also should know everything in detail about that. Okay. So the rheumatic fever, molecular mimicry, type 2 hypersensitivity, M proteins, antibodies are going to cross react with the myosin. All that is rheumatic fever. So next case scenario we saw was glomerulonephritis, where the patients will have a pharyngitis or a impetigo, and after approximately 2 or 3 weeks, you're going to have a post-infectious glomerulonephritis. Okay, so that is a type 3 hypersensitivity. This is type 3 hypersensitivity. This is type 2. Okay, this is type 2 hypersensitivity. This is type 3. Okay, so this is all the diseases of your Streptococcus pyogenes. So now with respect to diagnosis, what all clues they will give you is, so we have discussed about all of these virulence factor in detail. So now the same thing you have to measure. The ASO titer is there, or anti-DNA DNase B antibody is there, which is going to indicate your Streptococcus pyogene infection. Okay, but apart from that, I want you guys to know that you can have a necrotizing fasciitis, which is not given here, but they can ask you very commonly. Okay, necrotizing fasciitis is just the bacteria is going to spread rapidly through the tissue, deep fascia, skin, everywhere. Okay, all the extremities, perineal region, everywhere. The patient's presentation is they will have a history of like some minor trauma. Okay, they will have a history of some minor trauma. First, they will start as an erythema just in the skin. Okay, then they will go and swell, and you will have like a edema presentation, and you will have like the patient's pain. No, it's going to be so much of out of proportion to your examination findings. Okay, so the patients will obviously they're going to have a systemic symptom like a fever presentation and hypotension. Okay, so you will expect a case scenario where a patient is having like a previous history of minor trauma, now coming with the erythema of the overlying skin. So you have to know the symptoms for cellulitis also can start at the same. They had a cut and they have full erythema presentation. But here, the pain is going to be so high and it's not going to be related to the examination findings that you're seeing. So for necrotizing fasciitis, where the Streptococci pyogenes group A Streptococci is the common cause, you have to remember the 4 common causes of your necrotizing fasciitis. So one is going to be your group A Streptococci, group A Streptococci. So next is going to be your Staphylococcal aureus, Staphylococcal aureus. So next is going to be your Clostridium perfringens, Clostridium perfringens. Next is going to be polymicrobial, okay, polymicrobial. So these are all the common causes of necrotizing fasciitis. What you have to remember is the treatment for this is surgical debridement. You have to go for surgical debridement, of course, with the antibiotics, of course, with the antibiotics. Okay. So this is a patient of necrotizing fasciitis kind of case scenario. So I want you guys to remember necrotizing fasciitis, non-bullous impetigo, post streptococcal glomerulonephritis, rheumatic fever, and your entire pyogenic, toxigenic, and immunologic presentation for your streptococci pyogenes. Okay, group A streptococci. So now the next concept is group B streptococci. Group B streptococci is agalactiaceae. So agalactiaceae, the one thing that you have to know, left and right, they ask is your CAM factor. Okay, CAM factor is going to it's going to enlarge the area of hemolysis, which is commonly formed. Okay, because the patient is going to have a CAM factor. They're going to be PYR negative. It's given here. Hipurate test positive, PYR negative. Okay. So whenever you think about agalactiaceae, the case scenario is babies. Okay, they have themselves given babies because they will tell you the patient will have pneumonia, meningitis, sepsis, everything, but in babies. Okay, it's because it is usually colonized in the vagina. Okay, this is usually colonized in the vagina. That's why when you screen a pregnant woman around the 35 to 37 weeks of gestation, you will see that the patient are having like a positive vaginal swab. They will have a positive vaginal swab, usually because it's seen in the vagina. That's why it's seen in the baby. So same pneumonia, sepsis, meningitis, but in the babies, if you're seeing, it is group B streptococci who are having the CAM factor, who are having the PYR negative, who are having the Hipurate test positive. So these kind of patients, you have to receive, if they're having a positive culture, you should give them intrapartum penicillin or ampicillin prophylaxis. Okay. So for agalactasia, I've not seen anything more than like a pregnant woman or a baby kind of presentation. It's only this much. Okay. So next is Streptococcus bovis. With respect to Streptococcus bovis, you have to remember bovis gut. Okay. The meaning of that. Okay. And this is going to either cause your endocarditis seen with your colon cancer, I told you. Bovis is in the blood, means cancer is in the colon. You can remember that mnemonic. Okay. So till now, whatever we have discussed is majorly your staph and strep because it is a lot. Okay. So for tomorrow, we will be discussing the rest of the gram positive bacteriology. Okay. I will start gram negative only a day later. Okay. Thank you guys.